Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and increasingly about other infectious diseases as well. This is the week of June 20th, 2022. Globally, there have been, since the start of the pandemic, 541,032,000 cases, with unfortunately 6.3 million deaths. That's globally from COVID-19. Here in the United States, we stand at 86,500,000, almost 80,000 cases total, with 1,014,500 deaths from the start of the pandemic. In pediatric patients, the AAP report, which carries us through the week of June 16th to 2022, we stand at a total caseload of 13,624,605 children with COVID-19 since the start, which accounts overall for a cumulative percentage of 18.8% of all total cases, or a rate of 18,102 kids per 100,000 pediatric population. The tempo of pediatric cases, thankfully, has been slowing over the last couple weeks, in fact, and most recently we stand at 13.7% of the total new caseload for the week ending in June 16th. Here in Arizona, we are at a cumulative caseload of 439,011, so just over that 439,000 mark, 21% of the total cumulative caseload, and 23,000, almost 900 per 100,000 pediatric patients. We stand at a mortality number of 70 since the start of the pandemic. That's unfortunate pediatric deaths either due specifically to COVID-19 or to associated events such as depression, suicide, trauma, etc., and so forth. We are now number 3 in the country, if that's a positive marker, I guess, standing behind California at 71 deaths and Texas at 150 deaths. Keep in mind that that's not rated as a incidence, that is just total number of deaths reported. So in terms of pediatric population, we are probably, unfortunately, still at the very top. So that's where we stand in terms of the numbers. Where do we stand in terms of other stuff? And in fact, this week's questions have to do with the Omicron subvariants and also the very new news of vaccine approval for children under age 5. First, for the Omicron subvariants, we need to confirm that all of the world's population currently is experiencing disease caused by some variant of the Omicron variant itself. So going away from the very first, the BA1 subvariant of Omicron, the United States has recently experienced a mini surge to a moderate surge with the BA2 subvariant of Omicron. And then in parts of Europe and Africa, the BA4 and BA5 subvariants have achieved, I guess, predominance. And the United States typically follows the case attack rate and the epidemiology, which is set certainly in the United Kingdom and also, I guess, by extension in Europe. So the United Kingdom, just today, as I record this on June 22nd, has identified the BA4/BA5 subvariants as their predominant strains or isolates, I guess, of the Omicron variant causing disease. And the expectations are that as those BA4 and 5 increase their attack rate here in the States, that we will have them become our predominant strain. Why is this important? I think it's largely a predictive modeling situation, once again, in which, in the United Kingdom and Europe, BA4 and 5 are even more contagious than the BA2, which was even more contagious than the BA1, Omicron, and Omicron was about 30 to 50% more contagious than the preceding Delta variant. So each step of the way, each variant or subvariant that achieves national and international predominance seems to step up its infectivity. which on the surface of things sounds, of course, not awesome. In fact, rather unfortunate. However, the important corollary that everyone keeps looking at is how virulent are the subvariants? Certainly, as we encountered Omicron, it was a nasty in terms of its infectivity and created quite a precipitous climb in our case attack rate here in the States and elsewhere in the world, despite vaccinations, despite boosting, etc. However, importantly, the hospitalization rate and the rates of severe COVID-19 and deaths due to COVID-19 have continued to decrease. Not decrease rapidly, but trend downward. And those trends continue to be seen with BA4 and 5. What's interesting and is reported this morning from the United Kingdom is that BA4/5 variants, subvariants, seem to have returned again to a lower respiratory tract infection, unlike the BA1 and 2, which I think I've spent time discussing, seem to cause an upper respiratory tract infection. So children, young adults, adults who had an Omicron BA1 or 2 mostly presented with the flu from heck and sore throat and very much an upper respiratory tract process. So rhinorrhea, congestion, sinus pain, sore throat, cough, but not a deep lower respiratory cough. The BA4 and 5 seem to again be swinging back to being more tropic or more, pathogenic for lower respiratory tract disease. So returning to a deeper cough, bronchitis as the garbage can category for the adults, and perhaps more of a bronchiolitis or pneumonia picture for pediatric patients. However, that being said, once again, they're not causing severe disease, especially in those in the world who are immunized and immunized effectively, meaning 2 doses of an mRNA vaccine followed by at least 1 booster, and for those who are at risk, 2 boosters, so a total of 4 doses. United Kingdom actually has seen an increase in their attack rate of COVID-19 due to the BA4 and BA5 subvariants. However, they continue to see a decrease in hospitalization and fatalities. The overall vaccination rate in the United Kingdom, however, is another 10 to 15% better or higher than we experience here in the United States. And an accompanying editorial from this news release, Contribution to Science magazine, suggests that the United States experience may be a little bit worse than is being seen in the UK. To be determined. Certainly, we are seeing a current increase again in cases, probably due to the infectivity of BA4 and 5, but so far that is not being followed by a significant increase in hospitalizations or even emergency department visits in pediatric patients, and as I understand from our adult colleagues, or adult medicine colleagues, not an increase there as well. So yes, more infectious for BA4 and BA5. Yes, a return to lower respiratory tract infection, but so far not a discernible increase in virulence or increased breakthrough cases for those who are fully vaccinated. It certainly continues to be so that the vaccine series, two primaries and at least 1 booster, remains very effective against serious or invasive disease when compared to those who are unimmunized or under-immunized. So yay, great, wonderful, fantastic that continues to be a strident support or endorsement for vaccines against COVID. And of course, unfortunately, there will still be and continue to be breakthrough cases because each subvariant is sufficiently mutated to escape or have some immune escape, and thus infections or breakthrough infections will continue to occur and likely will continue to increase as we experience more and more infectious subvariants. That's the state of the world as we know it in terms of what's out there. In terms of vaccine prevention, there now is vigorous work occurring both by Pfizer and Moderna as well as other vaccine manufacturers to create a universal SARS-CoV-2 vaccine that would hopefully create immunity to targets that are not likely to mutate in any significant way. That is a shifting target, as you can imagine, and it remains to be determined if there will be a successful vaccine product that will actually have the clinical efficacy as predicted. very similar to the work being done for HIV vaccine and absolutely similar to that work being done for malaria, both of which have proven themselves to be immunologically difficult targets to get a reliable, focused, overriding vaccine to provide protection against all, subspecies or subclades in the case of HIV. So stay tuned, I hope, for more information about discovery in that realm. In terms of then vaccines, and this gets to the next question, what are we seeing in terms of trends from parents and certainly trends of vaccines for children under age 5? Presumably everyone has seen the media reports that first the FDA and then the CDC and Dr. Walensky, director of the CDC, have endorsed and approved both Moderna and Pfizer's mRNA vaccines for use in children ages 6 months and up, and a secondary approval by the CDC FDA for Moderna's vaccine for children ages 6 up through 16. So if you recall before, Moderna was really kind of lacking in that under 16, certainly under age 18 group. So we now have 2 vaccine products for all children ages 6 months and up. Fantastic, great, wonderful. The predicted efficacy of the vaccines remains in the 60 to maybe 70% range against infections, perhaps down to 50% with Omicron, but much higher efficacy ratings against severe or invasive disease. I'm sure you're all thinking, but we just don't see that much severe or invasive disease in children, especially the youngers, and that is absolutely true. But we do see infections. We certainly have been seeing breakthrough infections for kids older than age 5 who were vaccinated. And it is very true that younger children, ages 6 months and up, can certainly be, as I think the term is, plague vectors, certainly sources of contagious SARS coronavirus 2 to reinfect or infect their families, their caretakers, and especially those in their families who are at risk, i.e. Those who are older than age 60, older than age 50 even, those with immunodeficiencies, chronic disease, comorbidities, etc. So as we're having now conversations with our families about vaccinating their children under age 5, I think that the strongest reason offered is to protect the rest of the family from getting reinfected or breakthrough infection for those who are vaccinated. And certainly not to ignore clinical benefit to the young children. We certainly have had our share of young children being admitted with a COVID-associated bronchiolitis or upper respiratory infection, triggering reactive airway disease, triggering an oxygen requirement, and certainly co-infection with SARS coronavirus 2 and another respiratory virus such as RSV, rhinovirus, enterovirus, adenovirus, parainfluenza, has brought a fair number of children into hospital with anything from bronchiolitis to a croup-like illness to sometimes even a multifocal viral pneumonia. So there are some very strong and important reasons to proceed with immunizing our younger children now that we have the approval and the emergency use authorization. What is the safety profile? Actually, probably the best yet in terms of the vaccine products tested in the various age groups. Safety in terms of immediate vaccine reactions, mild reactions only that were reported through the studies. Certainly no, so far, increase in post-vaccine myocarditis, as we did demonstrate in children ages 12 and up. And just overall, that the young kids are tolerating the vaccine series apparently incredibly well. So that's fantastic. So safety and risk versus benefit, there's a fair amount, I would argue a strong amount of theoretic benefit to vaccinating the younger children and a minimal amount of risk to be encountered as the research now stands. So all this sounds like a very positive endorsement. However, the predicted uptake of the vaccine approval and vaccine now in children from 6 months up is not great. In fact, it's anywhere from maybe 10 to 15% anticipated vaccine rate in children in that age group, 6 months through 5 years. Reasons for that, I think we could all probably predict. Pandemic fatigue, vaccine fatigue, very, very, very long period of waiting for vaccine indication approval in this younger population. People just got tired of waiting and said, well, heck, we'll just have to deal with things as they occur. And maybe perhaps a fair number of children have already been infected. So I don't imagine there will be too many caretakers beating down our office doors for vaccine. I hope I'm wrong. I hope that they were able to continue to get the message out that the younger children absolutely need vaccination. Certainly, I've been speaking to the media in that regard, and I know many others nationally have been as well. So anything that we all can do as providers with access to the public to grow and build support for vaccine in the youngers is, I think, going to be very important. So there you go. That's kind of where we sit in terms of the COVID-19 pandemic as of this week in June. Briefly talking about other infectious disease threats out there, since I've started this conversation in the last podcast. Update on the fulminant hepatitis presumed viral etiology. These would be the children up to around age 8 or 10 years presenting after a viral illness with rapid onset liver failure, jaundice, hepatic dysfunction, requiring in some cases liver transplantation, and unfortunately associated in some cases with death. The initial epidemiology was suggesting that adenovirus 41 may be an important etiology in this situation. It's less clear that that is so, only because as additional cases have been gathered worldwide, that there's not as strong an association with adeno 41. It may potentially be a co-infection, a cofactor, or it may be that it just represents one of many respiratory viruses that has some enteric or GI tropism in the setting of a patient with potentially a genetic based susceptibility. So I think, although there are no smoking guns anywhere in the literature, the clinical suggestion based on the epidemiology so far is that this is likely a multifactorial process which may be associated with a viral infection. The good news, however, is that over the last several weeks, the reported attack rate of this process has dropped precipitously. A couple reasons for that. First of all, it may be a biased comparison, because if you recall that the first attention we had to this concern, fulminant hepatitis, came to us from Alabama, and a very astute clinician there who put 2 and 2 together and came up with 7 cases, which was amazing. And I mean, hats off to that person who was able to pick that up and report it. Then came a flurry of case investigation, most of which was retrospective. In fact, Israel came up with 50 cases in the first week after the Alabama situation was reported by going back in a chart review for the past 3 years. So I think many individuals, certainly in this country and elsewhere in the world, did exactly that. A retrospective chart revealing, oh, hey, I remember that patient, da-da-da-da-da. I wonder if they might have had this fulminant hepatitis. So I think that the rate of people now having completed their retrospective case review has dropped off, and we're not seeing any new finds. It is also likely, again, thinking prospectively, that the overall attack rate for this is quite low, and that the true risk for fulminant hepatitis viral etiology is actually also quite low. So whatever the etiologies and whatever the answers may be, it does appear epidemiologically that things have slowed down significantly in that realm, and that's great. I'm okay with that. Monkeypox is the other biggie out there, and as of this date, as I record this, again, June 22nd, Arizona has 1 confirmed case in Maricopa County. Not a pediatric patient, obviously won't discuss more in terms of HIPAA, but it is still a very, very, very unlikely risk for monkeypox to be found in our patients. Far more likely that those kiddos with what appear to be bullae or pox or pustules, that they have a Coxsackie virus infection. So not that there is zero risk, certainly that there have been several hundred cases. In fact, the World Health Organization is currently identifying over 650 cases worldwide, with a further 1,500 suspected cases, so patients under investigation, PUIs. So around about 2,000, maybe a rough guesstimate 2,500 confirmed or suspected cases in the world, both in Africa as well as Europe, the Middle East, and here in the Americas, North, Central, and South. So it continues to be demonstrated that the current monkeypox, gosh, I hate to use the term outbreak. I think we're making more of this than it really needs to be, but cluster of cases is perhaps the better descriptive. The current monkeypox experience remains largely demonstrated in adult men who have sex with men, with additional heterosexual transmission. It's not a traditional sexually transmitted infection, meaning transmission via sperm, vaginal secretions, oral secretions, etc., but instead it is a disease which is transmitted by close contact with an actively infected person, typically by exposure to infected secretions of whatever type, and or contact with infected and expressing pox, which themselves express virus. So the focus of investigation worldwide continues to be on sexually active hetero and homosexual individuals with close proximity, and unprotected intercourse is perhaps a red flag, but not a causative risk factor. Instead, it's just close proximity. In fact, I'll redirect our memory to one of the two of the major outbreaks discussed in Europe. One came from a rave party, which was just a lot of people in close proximity, and the other came from a bar in London. There is still, of course, lots yet to be discovered and determined, etc. I think overall the risk, from our perspective to children, is very low. Not that I urge anybody to ignore the possibility. I think we should all consider the possibility of monkeypox if we have a child with a compatible rash, and there are tons of pictures available to you online. You can just well, Google may have a couple pictures for you. I hate to say that. Certainly the CDC website has an excellent discussion of monkeypox, with some very instructive pictures of monkeypox lesions in their various stages. So I encourage you, if you haven't already, to take a look at the CDC website. You can link to that through the Arizona Department of Health Services as well, through their website. But just familiarize yourself with what a true monkeypox lesion looks like. Keep it in mind for that kid with the unexplained rash, but do keep in mind that epidemiologically the risk is remote. Good, great, wonderful. Last thing, just to touch on what else are we seeing out there, and this is in communication with community providers in Pima County, where I am, and also with pediatric emergency medicine providers. We continue to see a large number of kids coming in with a hypersensitivity rash. So think erythema multiforme major, with some elements perhaps even of a serum sickness reaction. So we've had children presenting with a typical erythema multiforme rash, including targetoid lesions, bordering then on an urticarial rash, so erythema multiforme urticaria, and then also having edema, including periorbital swelling, facial swelling, peripheral extremity swelling, and to some extent even sometimes joint swelling. So really bordering on to a sort of type 1 hypersensitivity, with some elements even of a type 2/3 hypersensitivity. And that there have been so far no specific uniform viruses that we are finding associated with that. There's been a smattering of various respiratory viruses, a smattering of treatment for atypical pneumonia, such as caused by mycoplasma. Certainly in Arizona, we always need to consider coccidioidomycosis, valley fever as a possible associated infection. But all these kids are responding well to supportive measures, antihistaminergics, in some cases requiring actually short bursts of steroids, whether it's dexamethasone or prednisone, for the edema components. But all are ultimately doing quite well. So just that's what's out there. And other than recognizing and managing supportively, I don't have a lot of additional advice for you. So that's where we stand. I will continue to monitor for new evolution and other infectious diseases and talk to you as those come down the pipeline. Certainly, please keep those questions coming. COVID and or anything else. I think at this point, anything we can do to continue our vigilance for infectious diseases affecting kids and staying up to date on COVID-19 issues for pediatric patients, I think it will be well supported. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to the email address covid@azaap.org. The AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And again, and as always, thank you all for your service to kids. Hang in there, keep smiling, keep wearing the funny clothes, and we'll talk to you next time.